Good afternoon, my name is Ava Brashear and I'm working under Dr. Elroy Aguiar and Dr. Kevin Crombie in the Department of Kinesiology to research the associations between habitual physical activity and post-traumatic stress disorder symptomatology. So what is post-traumatic stress disorder, or PTSD? It is defined as a mental health disorder where conditions such as excessive anxiety or major depressive disorder are sustained after experiencing a traumatic event. We most commonly hear this associated with groups of people like people who have served in the military. However, the reality is that anyone who has experienced a traumatic event can develop PTSD. Other groups of people who are susceptible to developing PTSD are refugees, people who have experienced natural disasters, first responders, survivors of sexual assault, and many more. Despite this disorder impacting so many people, only 1 in 4 people with PTSD in low or middle income countries report seeking any sort of treatment. So why are people not seeking treatment? To understand this, we must first look at the current treatments for PTSD. They are cognitive behavioral therapy, prolonged exposure therapy, eye movement desensitization and reprocessing therapy, and medication, all of which are prescribed in a clinical setting. The barriers to these treatments is that there's a lack of awareness that PTSD is even treatable, there's a lack of mental health care access, and there's a social stigma around receiving mental health care for disorders like these. Some research has been done to see if physical activity could be prescribed to be a more accessible treatment for PTSD symptoms. Recently, a study was conducted to examine the relationship between habitual physical activity and PTSD symptomatology. They asked trauma-exposed adults to complete a 2-stage mark-off task to be screened with the PTSD DSM-5 screening, in which they are given a numeric score for the level of PTSD symptoms, and to also complete the International Physical Activity Questionnaire. This quantifies the average physical activity of a participant. Analytical statistics were run to place participants into quartiles based on their self-reported MET minutes or their physical activity. And then those quartiles were compared to those participants' scores on the PTSD DSM-5 screening and also their 2-stage mark-off task. The conclusions of this study were that participants in the upper 3 quartiles of physical activity for this study displayed less PTSD symptoms. However, there was one major limitation. The fact that this study used self-report data made it more susceptible to over-reporting, recall bias, and social desirability bias, thus giving rise to our current research question. Does a trauma-exposed adult's level of physical activity, as tracked by a wearable device, impact their level of PTSD symptomatology? The current study seeks to address this issue of bias by researching habitual physical activity and PTSD symptomatology by looking at participant score on the PTSD DSM-5 screening, as well as looking at wearable device data. 3 studies were conducted by Dr. Crombie in 2019 that asked trauma-exposed adults to be screened with the PTSD DSM-5 screening and also wear a waist-worn actigraph accelerometer for a prolonged period of time so that physical activity data could be collected. As you can see here, the device was worn around the waist and the device captures activity data through the participant's movement. It is basically like a research-grade Fitbit. We will look closer at the type of data it collected later in this presentation. Because the accelerometer data came from 3 different studies, the first step in the research process was standardizing the data to make sure that the same information and the same amount of information was being gathered for each participant. Each participant's data was run through the ActiLife software, which validated the wear time and scored the data. Parameters to make a participant's data valid were that they had to wear the device for a minimum of 600 minutes for a minimum of 4 days and a maximum of 7 days. This is because 7 days is a standard research protocol for analyzing activity data. After these exclusions, we were left with 83 participants. As seen here, after the data is ran through the software, you can see a preview of a 24-hour period of wear time. The wear time is in white and the non-wear time is in blue. The intensity of the activity done can also be seen through the height of the black lines on the graph. Down at the bottom here, you have the option to set wear periods as wear time or non-wear time manually. We utilize this function when participants had more than 7 days of wear time and chose the day with the least amount of valid wear time to exclude from the data. From here, all of the valid wear days were scored by the software. All sorts of data can be gleaned from this. However, we will only be discussing the data points that are important to make conclusions about participants' physical activity habits in order to later compare them to their habitual physical activity to their PTSD symptom score. The first important variable is participant step counts. After scoring the data, we were able to use R to combine all of the data that gathered from each participant and run some basic analysis of the group's overall activity level. Here you can see a histogram of the participants' average daily step counts. The data is relatively normally distributed, with participants performing a mean of 8,342 steps per day. This sample on average would be considered to have the optimal step counts for positive health outcomes, as research is finding that 7,000 to 8,000 steps per day creates optimal health outcomes. We also wanted to analyze if participants might have been considered outliers that could be skewing the data. Shown in this box plot, the median for the step counts was 8,498 steps a day, and there was no significant outliers. Step counts gives us some insight into activity level, but it does not tell us the intensity of the activity actually being done. So we look deeper at the average MVPA per day. MVPA is a measure of activity intensity that quantifies time spent in moderate to vigorous physical activity. Here we see that this histogram has a little bit more variation, but it is also relatively normally distributed, with most participants falling here in the middle between 55 and 75 minutes in MVPA per day and a mean of 59.3 minutes in MVPA per day. The box plot tells us that the median time spent in MVPA was 59.8 minutes and there were no significant outliers. So even though we've looked at the total time in MVPA, we can't really know how this compares to the participants' overall activity until looking at the percent of their time spent in MVPA. These graphs show that the data is normally distributed, with participants spending a mean of 6.7% of their time in MVPA, and the median percent of time in MVPA was 6.78%, and there were no significant outliers. Now, when we analyze participant sedentary time, we can look at the average length of a sedentary bout. A study in the National Library of Medicine found that breaking a sedentary bout into increments of 20 to 30 minutes, rather than prolonged sedentary time, can decrease the adverse health effects. As displayed here, participants' sedentary bouts have far less of a range, but many participants fell within this 20 to 30 minute range, spending a mean of around 25 minutes in their sedentary bouts. However, 2 participants had an average length of sedentary bouts of 50 to 55 minutes. When taking a deeper look at the box plot, we see that the median amount of time in a sedentary bout was 24.8 minutes, and there were 3 outliers falling around 38, 51, and 55 minutes spent on average in sedentary bouts. Total average daily sedentary time can give us an even deeper insight into a patient's overall health. The Journal of American College of Cardiology reports that people who have over 10.6 hours of average daily sedentary time have increased health risks despite even meeting daily movement guidelines. As seen here, there are only 6 participants that fell over that 10.6 hours on average. Participants spent a median amount of time of 7.36 hours a day in sedentary time, with 2 outliers having around 13 and 15.5 hours of sedentary time a day. Later, we will look into if this hour mark also correlates with increased PTSD symptomatology. The overall conclusions on our physical activity data is that participants' data is relatively normally distributed on their levels of physical activity. So this will be a good sample to compare to the PTSD scores to see if there's any connections that can be made around if level of physical activity affects PTSD symptoms. We've only just begun analyzing the physical activity data with the project, so the next steps in the project are to work with Dr. Crombie to draw comparisons and correlations between participants' physical activity levels and their numeric score on the PTSD DSM-5 screening. This will allow us to draw conclusions on habitual physical activity's effects on PTSD symptoms, and the overall goal of this project is that this study may ultimately provide empirical evidence to support physical activity as a treatment for PTSD symptom management, which would make treatment more accessible, affordable, and less socially stigmatized. Thank you for listening. Do you have any questions?
So, from what I understood from the way that you analyzed the data, it looked like you were putting all the 83 participants together. I'm just curious, and maybe you don't even have this data, but even what your intuition would be if you were to go deeper in that and you were to pull the 83 out by, gender, age, maybe even like their job. Are they like sedentary? Or are they out working? So do you have that? Was that in your data collection that you could do something like that? And if so, do you have any kind of intuition on what that might reveal?
So we do have that data. We have not started analyzing it yet because we just started analyzing the physical activity data as a whole, but that is a part of our next step, is to analyze more in-depth participant demographics like that.
All right. I have actually a couple questions for you. First would be the clinical significance and clinical value of this research. And second would be, do you expect to see more of like a dose-response relationship with, depending on kind of like Dr. Gray was saying, the, let's say, occupation and whether it's a physically active occupation, like you said, with someone being in the military or someone being, for example, in like paramedics, or as a firefighter versus someone that's more sedentary, maybe someone affected with a natural disaster? Like, do you expect to see differences within those populations within your research?
So the clinical value of this research is that physical activity is known to have a wide range of health effects, especially with physical health. But this is looking deeper at if physical activity could become a first-line treatment for mental health disorders, which would widely deepen the accessibility of PTSD treatment, especially for those in low income or just people that don't feel comfortable seeing more of your standard PTSD treatments. And then as far as the dosage question, that's hard to say considering we haven't looked at the occupation specifically. We haven't looked at the demographics, but it'll be interesting to conclude whether there is connections between that once we start getting into that analysis.
So are you also asking the participants like their perceived amount of activity? I'm not sure how much this would really matter for PTSD in particular, but it seems like it might make a difference if like their moderate to vigorous activities like lifting weights, for example, versus just going on like a hard hike. So are you also asking like what kind of activity they're doing, or is it just monitoring with the belt?
So we have, to my understanding, we have not asked them their perceived physical activity. That kind of would get into the limitations of the last project of self-report data increases bias, but we could ask them. That could be the next step in the study.